Hello, everyone, and welcome to today's CAP webinar. We are really fortunate to have our speakers today, Drs. Dave Manoli and Petra Steinbuchel. Dr. Dave Manoli is Assistant Professor of Psychiatry in the UCSF Weill Institute for Neurosciences. He is a child and adolescent psychiatrist and a neuroscientist whose research focuses on the neural circuits mediating social behavior, using molecular and genetic approaches to study social attachment in the context of environmental and genetic factors known to be associated in their outpatient and full-based clinics with medically underserved populations, as well as in outpatient integrated care models in consultation with pediatricians. And Dr. Steinbuchel also serves as the director for CAP. And with that, I'll hand the virtual mic over to Dr. Steinbuchel.
Thanks so much. And I'm super excited to do this talk with Dave. And if you ever have a chance to check out his research in other areas, it is really, really cool. But today we're going to be talking about mood and psychotic conditions in pediatric primary care with a much stronger emphasis on the psychotic component. Next slide, please. So we do have some federal funding through HRSA. And we also have some sponsorship through the Department of Healthcare Services for behavioral health integration. Next slide. Our objectives today are going to be to look at the key elements of mental status exam in evaluating psychosis and mania, because everything really starts with trying to hone in on diagnosis as much as possible. And then also look at the potential etiologies of psychotic symptoms in children and adolescents. We want to try and better distinguish symptoms that are more frequently associated with severe mental illness, like bipolar disorder, depression with psychotic features, and schizophrenia spectrum conditions. And we're going to look a little bit at what are the assessment priorities in pediatric primary care, including safety and also medical evaluation. And then we'll name at least one intervention and associated indication in these disorders. Next slide. So mental status exam is something that we were taught in nursing school and medical school, and it's part of an overall physical evaluation. And it's something that, you know, a lot of us kind of take for granted, and we rely on our kind of verbal communications and more what you hear, rather than looking at kind of the whole picture of what are we seeing. And so it's really important to look at what are the nonverbal communications that are happening, because about 70% of communication is nonverbal. And then also to try and ask yourself, what does it feel like to be with this person? That's a really important thing to notice, whether you're evaluating for psychosis or anxiety or depression or, you know, a number of other conditions, that you can just kind of notice what you're feeling from the youth. And then how does this align with what you hear? Because sometimes there is a real mismatch. People can be very bright and articulate and highly verbal, and that all sounds very plausible. But if there's a disconnect with what they're saying and how they present, that's really important to pay attention to. And these are the kind of key components of the mental status exam. Next slide. So psychosis, defined as really difficulty perceiving reality and difficulty with having coherent linear thoughts, and can manifest in a few different ways. The most common one that I think we think of is around hallucinations, which are really perceptual disturbances, and think about auditory, visual, tactile. Delusions are more fixed beliefs or ways of interpreting the environment that are not based in the reality that most other people experience. And then also there can be thought disorder, which is manifested as disorganized thought and speech. Next slide. So there can be a number of possible reasons, and the bold part here is probably the most important piece of this. And Dr. Manoli is going to speak to this a little bit more as well. But most children who exhibit psychotic or psychotic-like symptoms don't have a true psychotic disorder like schizophrenia. The most common drivers for this are anxiety and depression. You can have brief psychotic phenomena in a number of different ways and for different reasons, including following trauma in relationship to borderline personality. If you think about someone who's experienced trauma, this may be kind of a mood congruent and more reality-based type of hallucination. Like people will describe, hearing a single voice telling them that they're no good. And it may be kind of the voice of whichever perpetrator of trauma was doing that, rather than something that's more bizarre associated with schizophrenia. You can have it in about 7.5% of teens, and then around 17% of children have psychotic-like experiences that are usually brief. You can also have hallucinations upon either waking up or going to sleep. And you can have it in a number of different conditions, including not only psychosis, but also bipolar disorder, PTSD, as you said, and autism spectrum, and then OCD. And we'll talk a little bit more about that a little bit later. You can have it with both prescribed medications. A common one could be a steroid medication, with IV steroids being kind of the most likely, and then less so with oral or inhaled steroids. And then, of course, with a number of different illicit substances. One note is also in medical conditions, and we'll touch on that briefly. You can have delirium. And really only a fraction of these go on to develop a true schizophrenia spectrum condition. And the diagnosis may often change. Next.
So one of the important things to remember is that in the context of what ends up becoming a true psychotic disorder, it's very rare that the initial presentation actually is any form of the psychotic symptoms that we end up observing as these kids get older and then progress into the disorder. And so what this really, this slide is sort of intended to represent are that long before we see the onset of psychotic symptoms in the general pediatric setting or in the psychiatry clinic, we do observe a very host of non-specific symptoms that are also the precedent to what ends up becoming this neurodevelopmental disorder that results in psychotic symptoms. Importantly, it's important to remember that about 23% of kids who eventually develop a psychotic disorder don't have any antecedent neuropsychiatric symptoms. But what we do see is that we see speech or motor delay, or abnormalities. We do see some individuals who will report some form of psychotic-like symptoms. But the flip side of that statistic is that it's about 70% of children at some point during childhood will report some form of psychotic-like phenomenon. And the vast majority of those have neither a psychiatric illness nor a true psychotic psychiatric illness. And so it's important just to recognize that there are developmentally appropriate reports of these sorts of phenomenon that obviously in the context of what a child is presenting with then become really important. And we're going to talk a little bit more about that evaluation. And then the final group is just what we lump into this category of social, emotional, behavioral problems, again, that are very non-specific and can actually represent many, many other forms of neuropsychiatric conditions independent of a psychotic illness. Next slide.
Oh, I think this is one that we have to click through kind of multiple times to get to see the whole thing. But this diagram, we won't spend a lot of time on, but just thinking about what is someone's thought process like? Is it linear? Is it organized? Do they get from this says Q to A? I might say more from A to B, and you can follow along and actually arrive at your destination. Circumstantial is if it takes a longer time to get around to what was the point. Next. Tangential, we've all experienced this, people, going on and on talking, and then what was the question again, and really missing, the point of getting to the end. Loose associations. This is something that you can see in both psychosis and in mania, where it's kind of unrelated thoughts that go from one to the next. And a flight of ideas is just completely unconnected tangents that really do not relate to one another at all. Word salad is, a lot of words that do not hang together. And this is not just kind of thoughts that are, all over the place, but really more so words that are just not even hanging together to form a complete sentence. And clanging is kind of words that sound similar and repetition of those and around those. Next.
So Petra just sort of demonstrated and sort of illustrated the different forms that cognitive disruptions occur in the context of psychotic illness. And so I'm just going to focus a little bit on sort of the other sets of symptoms that we see. In the context of what we call positive symptoms, we see things like hallucinations, which are perceptual disturbances, for example, seeing or hearing things, or in fact smelling things, which is the most common form of hallucination that others aren't perceiving. In the context of, for example, auditory hallucinations, they can be voices that are, sort of perceived in the head, outside of the head. There can be multiple voices. They may in fact talk to each other. And an important feature is, as sort of these conversations are happening with a child, that no specific traits of hallucination seem to be indicative of quote unquote formal psychotic illness versus not. And so it's really important just to sort of work and speak with the child, just to both sort of normalize in the context of what their experiences are, to really sort of just get a survey of the sets of symptoms that they're experiencing. Sort of along the lines of other positive symptoms aren't really there, for example, distorting a coat rack as a person, or sort of other disruptions in actually perceiving held despite sort of evidence to the contrary. And this sort of also then becomes an important feature of traits that sort of represent the conversion from sort of the earliest stages of psychotic illness into what we would call sort of a formal psychotic illness. And we can talk a little bit about that in more detail. But, delusions can be anything from delusions of being controlled, erotomania, sort of fixated sexual fixation on individuals, grandiosity, as well as sort of cognitive disruptive delusions like thought insertion. The other side of psychotic symptoms is what we call negative symptoms. And so Petra discussed the cognitive disruptions that we see that fall into this category. But another important feature, or two other important features, are what we would say are sort of thought slowing or thought blocking, that kids can report that it's much, much more difficult for them to concentrate. It's much more difficult for them to even sort of come through the haze of their thoughts to really articulate their ideas. And then the other domain of cognition being social cognition, where the kids start to interact less, express emotions less, have less social motivation in general. And in the context of these formal psychotic illnesses, that actually is the most important for looking at prognosis in terms of premorbid social cognitive function. Next slide, please. And so, just looking very quickly at the sort of stages that we're talking about, really what we're focusing on for the purposes of this conversation is really what's in green, sort of this premorbid phase where children have either no symptoms of a formal psychotic illness, or these very nonspecific symptoms that are consistent with multiple neuropsychiatric conditions or neurodevelopmental disorders. Sort of as we move into the early teen years or the late teen years, that's when we start to see, again, in the context of formal psychotic illnesses, what we call attenuated psychotic symptoms. And we'll talk about that in a little bit more detail. But I think for the purposes of this audience, what we're really talking about is sort of paying attention to this sort of green premorbid region, and then trying to figure out when is it and is it appropriate to refer for psychiatric evaluation after some of these areas have been probed in more detail. Next slide, please. So, the reason that we pay a lot of attention to both these early and then attenuated symptoms is because once we identify patients who are at risk, it's really important to sort of try to facilitate their entry into a treatment program. And that doesn't specifically mean pharmacology, and we'll talk about when, or I should say antipsychotic pharmacology, and we can talk about when there are indications for that. But what we do know is that from a support standpoint and from a therapy standpoint, the earlier individuals enter into a treatment program, the better the overall prognosis is. Importantly, early diagnosis and early recognition of psychotic illness can prevent some of the disruption of developmental milestones, both academic, social, and sort of cognitive performance. An important fact is that there is a 10% incidence of suicide in patients with a psychotic illness within the first 5 years, and so from the mood perspective as well as from a protective perspective, getting them into care and having them monitored is a very important intervention. Formal psychotic illness is among the top 10 leading causes of disability worldwide. And so again, we're talking about factors that really lead to significant disruption of productivity as well as well-being. There's a significant risk of homelessness, and perhaps by virtue of that, given sort of the state of things and increased interaction with the criminal justice system. The overall risk of violence is low, and it's important to recognize that by itself, sort of formal psychotic illness is not necessarily predictive of an increased risk of violence, with very specific exceptions. But the important factor is there's often comorbid substance abuse that can lead to an increased incidence of violence. For women, there is actually a significant or double the rate of sexual and physical abuse if they have a formal psychotic illness. And importantly, right now we're looking at about a 2-year average delay to treatment, which again speaks to both access to the healthcare system, but also patients who are actually having untreated psychotic illness, which we know can actually reduce the likelihood of an overall good prognosis. Importantly, I think that there is this important balance between diagnosing what is actually, sort of a clinical high-risk syndrome versus, or a formal psychotic illness versus a false positive, and really the earliest interventions and diagnostic assessment periods are to really figure out whether or not a patient should be in this category or not. Next slide. So I'm just going to very quickly run through sort of the other diagnostic categories or that sort of arise in the discussion of formal psychotic illness in children. So, what we eventually end up talking about is the diagnosis of schizophrenia, which in the context of these formal psychotic illnesses is the most common. But there are other disorders that do appear earlier in life that albeit at a much less significant rate. So childhood onset schizophrenia is defined as developing before 13 years of age. We see rates of 0.1 to 1% of schizophrenia presenting before the age of 10. And so it's very rare and is clinically distinct as well as genetically distinct population. There still is a male preponderance early on, but then later on in life that it seems to equalize in terms of the rates of childhood onset. Not perhaps surprisingly, the early onset of symptoms and disruptions to cognition as well as social cognition really do sort of predict a very poor prognosis. And consistent with this, we see that these children tend to have significant premorbid both personality as well as neurodevelopmental abnormalities that are detected, again, usually in the pediatrician's office. Next slide, please. Moving a little bit later, sort of in the developmental timeline, there's a category of what we call early onset schizophrenia, which is really schizophrenia that develops and sort of becomes diagnosed as sort of a formal psychotic illness after puberty, but prior to sort of the 16 to 18 years of age. About 4% of these patients are presenting within by age 15. And there's an important overlap with the autism spectrum disorders, which we'll talk about briefly. One thing that is actually important is that in these patients, what we see is that the content of delusions and hallucinations tend to reflect what's sort of appropriate for the developmental stage. So for example, a younger child may have thoughts about their toys or thoughts about monsters, as opposed to some of the more frequent hallucinations that patients who present sort of in the late teen and early adulthood period. Next slide, please. And so then when we move to sort of the schizophrenia spectrum disorders, that's sort of what we see as sort of the more sort of typical presentation of what is usually diagnosed in the late adolescence, early adulthood period. The frequency is sort of anywhere, about 3 to 100 by some estimates. Onset can be anywhere from sort of 16 to 35 years of age, and there is a significant difference both between men and women in terms of the frequency as well as the peak age of presentation. With boys, we sort of see it in the very late teen period. We think about the transition just from a sort of epidemiologic standpoint of happening at the sort of high school graduation age. For women, this tends to be a little bit delayed, and so sort of thinking about the college graduation time period, and obviously these curves overlap, but what we do see is that women tend to be presenting and diagnosed later on. There is also, interestingly, a second peak for women that happens around menopause that I think for this conversation isn't necessarily relevant. But importantly, what we do find is that because of this earlier onset, and whether it's because of the lack of as long sustained relatively healthy development, men tend to have a more severe set of symptoms than women do. Although again, that overlap is pretty significant. Not surprisingly, there is a strong genetic component. There is an increased risk if there is a first degree relative. We'll talk about in a little bit more detail. There is an increased risk in the context of cannabis, particularly more recently with the strength of marijuana that exists now relative to a couple of decades ago. And then there are environmental factors. We do know that both migration, early adverse childhood events, as well as intrauterine infection, for example, can actually significantly increase the risk at an epidemiologic level. Next slide, please. And so when we're talking about schizophrenia, we've reviewed sort of the earlier presentations that are independent of sort of the adult onset form that we most commonly are thinking about. Thinking about the criteria, what we find is that at least by diagnostic criteria requires at least 2 of the following within a 1-month period. So delusions, hallucinations, and disorganized behavior, which are sort of these positive symptoms, and then things like catatonic behavior or the other negative symptoms of sort of affective flattening, deficits in social cognition or social processing, can also occur and are part of the diagnostic criteria. And this is something that is sort of shifting from in the research standpoint, where there are sort of what we call bizarre delusions or delusions that are completely not based in reality, only one of those symptoms is also necessary. And so that's something that is thought to represent a potentially increased risk or level of conversion, although this is a question that is actively being investigated in the context of clinical research populations. Next slide, please. In terms of thinking about the epidemiology of psychotic illness and in particular schizophrenia, it's important to recognize that there are sort of structural inequities or differences in terms of how the diagnosis is applied, in particular with racial differences. Consistently, and this is something that even into the most recent years hasn't changed significantly, African Americans are diagnosed anywhere from 2 to 3 times the rate of non-African Americans in the United States with a diagnosis of schizophrenia. There are differences both that also scale with socioeconomic status, and part of it also is clinicians' interpretation of a patient's own report. And so it's very important to recognize the context in which a patient is presenting, whether we're talking about a pediatric or an adult population. Next slide, please. Sorry. So again, I'm not going to sort of belabor the point, but the most important thing to remember is that when we're talking about this in the general pediatric setting, that it's very rare that a patient who ends up having a formal psychotic illness initially presents with those. And that's why I think the early neurodevelopmental time course and sets of soft neurologic symptoms that can just be associated with a large spectrum of disorders are very important to be cataloged and are an important part of the history to really understand the trajectory that a patient is taking. Slide, please. So I'm going to briefly focus on what we call the ultra high risk or the clinical high risk group. And that's sort of the category that from a diagnostic perspective that we really sort of want to have enter the treatment pipeline and really sort of engage with treatment early on. both because we know that treatment interventions, in particular the non-pharmacologic ones, actually do have a significant impact on prognosis. And so the group of ultra high risk patients sort of falls into sort of two or three different categories. The first is this attenuated positive psychotic symptom set, and that's the presence of one of these sets of symptoms with a frequency of a couple of times a week, presenting, with symptoms within the last year, or in a duration of more than a week and less than 5 years. And from a research perspective, and this is something that sort of is post-referral, what we're really looking at is the level of conviction that these patients have about their symptoms. And then that can be contrasted to what we call the brief, limited, intermittent psychotic set of symptoms, where this conviction can sort of fluctuate between episodes of conviction and then sort of falling back to these attenuated symptoms. And so if these symptoms are happening at a frequency of less than 1 week, happening with the frequency of more than 1 week, but a duration of less than 1 week, we actually call them a brief psychotic episode. And again, these have to have occurred within the last year. And then sort of in addition, and perhaps outside of the context of what we're talking about in the sort of general pediatric setting, there are these sort of trait factors that figure into attenuated symptoms that may not meet full criteria for this clinical high risk population that we then think is potentially at increased risk for moving to formal psychotic illness. Next slide, please. Actually, I think for the sake of time, we can skip this because we have discussed some of the specifics of what these symptoms present as. So I'll turn it back over to Petra.
Thank you, Dave. So these are a couple of examples of kids that I've worked with, and they're somewhat de-identified. But one is a 10-year-old adopted English speaking cis female who was presenting with acute intermittent episodes of really a lot of increased motor activity and also self-injurious behavior, including something that was a little bit bizarre, picking her nose to the point of bleeding, and then actually using the blood to write on the walls, and also talking about having a visual hallucination of a shadow of a male figure who is telling her to hurt herself. This girl actually had experienced really significant early childhood abuse, neglect, and also exposure to sexual content. Next slide. This patient is someone who at the time was 17, adopted, cis male. He had been diagnosed with ADHD at age 6, and his history included that he was in utero exposed to what was thought to be multiple substances. He also experienced really early severe neglect and had not learned how to speak until age 4. And he had really significant gross and fine motor delays. He started to speak shortly after he was adopted. And at the time of adoption, there was a reported family history of bipolar disorder. He started to demonstrate more social anxiety and withdrawal and started to refuse to go to school at age 13. And the anxiety had been fairly longstanding, but it really seemed to get worse in 8th grade when he was feeling more teased and bullied by his peers. And then around age 17, he had this recent suicide attempt by drinking nail polish remover, which is an unusual method of trying to kill yourself. And then that was when he was starting to talk about wanting the shades to be drawn more due to worry that people were looking, potentially spying on him and the family. And I share these with you as we walk through a little bit more about these disorders, because these are real examples that we'll come back to, and I'll share follow-up.
Great, thank you. And so, as we've already sort of discussed briefly, there's a very large differential when we're looking at the initial presentation of psychotic symptoms in the pediatric setting. And this can include neuropsychiatric conditions such as affective disorders, anxiety as well, being one of the major drivers of the initial presentation, that then eventually develop to mood disorders with psychotic features. And this can be both major depressive disorder with psychotic features, as well as bipolar disorder, both of which, in the context of depression or mania can present with psychotic symptoms. And then we've sort of already listed some of the primary psychotic disorders, in particular schizophrenia, the brief psychotic disorders or schizophreniform disorder. And then in the context of the absence of other forms of positive symptoms, delusional disorder actually has its own specific diagnosis. An important sort of second diagnosis in the context of formal psychotic illness is schizoaffective disorder, in which we see this intersection between mood symptoms as well as psychotic symptoms. And interestingly, actually, these patients actually have an overall better prognosis relative to those with a diagnosis of schizophrenia. As I alluded to, there are sort of personality disorders that include subsets or overlap with some of the attenuated psychotic sets of symptoms. And that can include the schizoid or schizotypal personality disorder, as well as in the context of borderline personality disorder, both at baseline, but then also certainly when symptoms are exacerbated, patients with borderline personality disorders can report active psychotic symptoms as well, and have conviction even. Importantly, thinking about this now from the general pediatric standpoint, there are many other causes of psychotic symptoms that don't include sort of a formal neuropsychiatric condition, and that can be substance-induced, both from sort of iatrogenic as well as sort of drug abuse, complex trauma, medical conditions, as many of you are familiar with, can, in the context of severe illness, result in the incidence of psychotic symptoms. And then, as we've talked about, the attenuated psychotic syndrome. Next slide, please. So here's just sort of a certainly not exhaustive list of many of the substances that can contribute to psychotic symptoms. And I don't want to belabor this list. We've already covered some of these, but I think it's just important to recognize that in addition to things like substances of abuse, we actually know that many medically prescribed compounds can, in certain contexts, result in psychotic symptoms. And an important context, especially for pediatrics, is that individuals who have neurodevelopmental disorders seem to be more sensitive to the development of psychotic symptoms in response to some of these categories. And so that's just something to really think about in the context of children who have a diagnosis prior to treatment, that they may actually be more likely to present with these clusters of symptoms. Next slide, please. Now, an important sort of individual risk factor that has sort of emerged over the last now 10 years in particular, this is actually one of the questions that was asked, is cannabis. And initially it was thought that cannabis was sort of, prior to maybe 10 to 15 years ago, that cannabis, while it was associated in terms of cannabis abuse with patients who have psychotic symptoms, or eventually describe it, that it wasn't something that was necessarily causative. We do see increased rates of cannabis use and abuse in patients with either attenuated or reports of psychotic symptoms. But more importantly, what we also know is that individuals who are sensitive for the development of psychotic illnesses are in particular sensitive to the development of psychotic symptoms in response to cannabis use. And so more recently, what we've actually found is that given the increased sort of levels, for example, of THC in particular in modern cannabis, that actually it does appear that not only does cannabis abuse contribute to an earlier onset of psychotic or attenuated psychotic symptoms and psychotic illness, but it actually does seem to now be increasing the rates of psychotic illness in the at-risk populations. And so there does a causative correlation, and I say that very explicitly, that it is still only correlative, both in research as well as clinical models, but we are seeing a significant increase in rates as well as severity of symptoms as a result of cannabis use. Next slide, please. So when we're talking about cannabis use, we're not necessarily talking about sort of the once a month sort of use that may be more frequent in sort of, for example, teenage populations, but we are looking at individuals who are chronic users, and that can be anywhere from 3 to 5 times a week, or daily cannabis use. And we see that they have a 2 to 3 times increased incidence of schizophrenia relative to non-users. And again, the correlative component is a really important factor, that we do see that, especially in younger populations, as opposed to nicotine abuse, that cannabis use is significantly increasing more over the last 10 to 15 years. It is something that has been at a case study level associated with increased rates of violent behavior. That's in the context of other substance abuse as well. And more importantly, though, cannabis use does increase the severity of symptoms, the morbidity, as well as the relapse rate. Next slide, please. So an important subset of patients that we know that are at increased risk of the development of psychotic symptoms are patients with a diagnosis of autism or autism spectrum disorders. We see that patients with a diagnosis of autism are that about 15 to 30% of these children develop psychotic symptoms. We know from a genetic perspective that there is some overlap between autism spectrum disorder and patients with a psychotic illness, and that we also see that there is an overlap in the pattern of deficits in social cognition. Importantly, in the pediatric setting, we see that children with a diagnosis of autism that do develop psychotic symptoms develop them earlier than patients without. And so that's now thinking about somewhere around maybe the even 11 to 14 or sort of 13 to 15-year-old range, as opposed to sort of the range that we were talking about in the context of schizophrenia. Next slide, please. Another important comorbidity that often is first sort of observed in the pediatrician's office is obsessive compulsive disorder. So just to briefly kind of go through sort of the details, obsessions in the context of OCD are persistent thoughts, ideas, images that are perceived as senseless or also intrusive. Compulsions are urges for actual behavior, such as repetitive, intentional stereotype behaviors that often, when patients are able to articulate it, are performed to alleviate the anxiety of the obsession. The prevalence of OCD is about 1 to 3% in the population. 21% of patients with OCD have an onset by the age of 10 years of age. And the mean onset for pediatric OCD is again right around this age, with boys being slightly earlier than girls. An important sort of association for the purpose of this conversation is that a diagnosis of OCD in the context of a child who's presenting in the clinical high risk increases the risk rate by 7-fold for the development of psychotic illness. And so there is a very, very strong association for OCD in the context of this clinical high risk population that's important from both a neurodevelopmental as well as sort of a natural history standpoint. Next slide. So we do see that there are patients that have psychotic-like symptoms that are, as I mentioned, sort of part of normal development. And just going back to OCD, as many of you know as pediatricians, there are sort of developmentally appropriate patterns of repetitive behavior that then sort of go away as a child sort of goes through the normal stages of development. And so it's important to take that into consideration. Psychotic symptoms in patients less than 13 years of age, as I mentioned, are common and not often associated with pathology. Older than 13, that's when we start to think about the clinical high-risk population or other causes that are leading to actual psychotic symptoms. And so that's important from the context of what a patient's or a child's sort of level of cognition is, the other things that are contributing to that, as well as the factors that might be leading to the onset of psychotic symptoms. If the sort of psychotic symptoms that they're reporting include things like bizarre ideas, significant changes in behavior, in particular, and as well as sleep disturbances, paranoia, themes of persecution, we do find that there is a potentially increased risk for the development of some form of a neuropsychiatric disorder. And then importantly, in the context of disordered communication, that speaks to significant disruptions in cognition that are associated with a poorer prognosis. Excuse me. Next slide, please. So just to kind of think about, sort of what happens after this diagnosis occurs, just thinking about sort of the overall natural history of schizophrenia and some of these disorders, we know that they're phasic disorders, right? That they have sort of these early clinical high-risk populations, and then following conversion, there is still a waxing and waning of severity of symptoms. As we've already talked about, there is actually a significant risk of suicide in these patients. And so, the most important intervention is really engagement with some form of treatment and monitoring. We do know that patients have an increased risk for both cardiovascular disease, diabetes, and substance abuse. years. This is both from a sociologic standpoint, but also from a biological standpoint, that these patients are, they seem to be at risk for other forms of medical morbidity. Interesting and importantly, about 50% of patients, though, are actually able to return to age-appropriate and academic training appropriate roles if treatment is established early on. And so that's why, again, in these critical years, really engagement is the most important thing in terms of ensuring prognosis. Excuse me, next slide, please. And so now, sort of, again, very briefly moving outside of the pediatrician's office, just to sort of talk about what this clinical high-risk population actually represents. So if we take individuals who present to a psychiatric setting, seeking help, for any subset of symptoms that fall into the category of these attenuated or psychotic-like symptoms, 5% of them actually just end up being completely healthy. And so whatever the situation is that leads to these symptoms resolves, and no further diagnosis is actually made. 65% of these patients, so now a total of 70% of patients, will have a diagnosis other than a formal psychotic illness. And so it's important to recognize that even though patients are reporting these symptoms, there can be, as Dr. Steinbuchel mentioned, a trajectory that does not include a formal psychotic illness. So then we take the remaining 30% that is in this clinical high risk, and of that 30%, about 30% will eventually develop a formal psychotic illness, with the remaining 70% not having a diagnosis at 2 years. And then some of those after that will have the diagnosis of other neuropsychiatric conditions, out a remaining third of them having persistent attenuated symptoms, but never actually converting to what we would say is a formal psychotic illness. Next slide, please. And so now, just to sort of briefly talk about what would happen in the psychiatrist's office, there are a number of assessment tools that we use to sort of determine whether somebody falls, first of all, into this clinical high-risk population, and then determine if they've actually converted to a formal psychotic illness. And for the sake of time, I won't belabor the details of this, but next slide, please. One important thing that is very important from a natural history and sort of a pediatric history standpoint are adverse childhood events. So the number of trauma events that a patient has experienced, which actually, from a statistical modeling standpoint, are a significant risk factor. So what I'm showing you here is the Naples risk calculator. That was a very large scale study looking at the factors that predict conversion from this clinical high risk population to formal psychotic illness. So just to say that trauma is a very, very important factor to take into consideration. So we're coming up towards the end. So if we could skip the next slide. And I will turn it over to Dr. Steinbuchel.
Thank you. These are just a few language pearls that sometimes can be helpful in assessing and just kind of breaking down the criteria into more plain speak. So ones that are commonly used are, do you ever feel like your mind is playing tricks on you or just not working quite right? Another way of doing this is when you're doing kind of a review of systems. Do you ever have problems with your eyes, with feeling like you're seeing things that other people don't see, or hearing things that other people don't hear? Have you ever felt confused about something, whether it's real or imaginary, or feeling like the world may not be real? Have you ever had your thoughts be so strong that you felt like you could hear them, or that other people could? And then again, with eyes, feeling sensitive to light. Have you ever felt like people are following you or spying on you? Do you have trouble understanding what people are saying or getting your point across? If we think about that logical linear thought process that may be derailed in this. And then, have you ever felt like you're not in control of your own ideas or thoughts? Next.
And so now, thinking about this initial sort of setting where a patient is reporting symptoms, thinking about the primary care setting and what interventions or sort of workup are important. So obviously a full history, as we've discussed, including family history as well as a neurodevelopmental history. Physical and neurologic workup actually is incredibly important, as I mentioned, because of the presence in many of these children of sort of non-specific, what we call soft neurologic symptoms. It can be worth, and often is worth, considering an MRI, especially if patients are suddenly presenting with symptoms. What we do know is that in the context of formal psychotic illness, MRIs in fact, do not seem to reveal anything structurally, but in the context of other causes, it can be an important part of the workup, as is EEG or LP for other medical causes of the onset of psychotic symptoms. And then sort of a host of labs that really sort of both determine the baseline function of various systems, as well as then sort of start to point you in different directions depending upon abnormalities. And certainly from the perspective of a general pediatrician, really sort of running through a baseline set of inflammatory signs of inflammation or infection, metabolic workup, neuroendocrine workup, and then infectious disease. Certainly in the presence of any neurodevelopmental syndrome, then we look at sort of other factors, including sort of gastrointestinal function and things like that might actually contribute to metabolic causes of some of these illnesses. Next slide, please. And then, sort of thinking about now the population that doesn't have a medical, medical cause, what do we then think about doing? And so that there is a very significant, not debate, but also important decision structure about whether or not to treat, in particular pharmacologically. The important factor is that engaging somebody in a treatment program from an epidemiologic standpoint is incredibly important, because what we do know is that the duration of untreated psychosis contributes sort of in a stress diathesis model to neurotoxicity and poorer clinical outcomes, including severity as well as relapse rate. And so that's where referral and attempts to engage a child and a family become very, very important. Next slide, please. And so that's sort of the basis of the last 2 points here, is where we see both the individual as well as family psychosocial interventions and therapies being very important for both decreasing the sort of the environmental stresses that are contributing to symptoms, as well as their onset as well as severity, but also supporting the cognitive development of these children as they sort of are proceeding into adolescence and adulthood. And then the last component of treatment is pharmacotherapy. So we can go to next slide. When we're talking about the use of antipsychotics, in particular in the clinical high-risk syndrome, I'm going to really focus on first the last point that's highlighted in red, that what we do see is that in the clinical high-risk population, the initiation of antipsychotic medications does not decrease the conversion to psychotic illness. So antipsychotics are not preventative. That doesn't mean that in the context of severe attenuated symptoms that they cannot be helpful for symptom attenuation or amelioration. But thinking about this from the overall perspective of affecting overall prognosis, the initiation of antipsychotics is not indicated. Importantly, we do see a significant increase in the rates of atypical antipsychotics over the last 20 years in children that end up not having a formal psychotic illness. So for example, 50% of prescriptions of atypical antipsychotics occur in children with ADHD and other non-psychotic illnesses. And so it's really important to have some form of diagnostic certainty to really say, is this a patient population, or is this an individual where there is data for the population that antipsychotics are indicated. Next slide, please. And so just briefly, what I've listed here are the atypical antipsychotics that actually have FDA approval for use in children. And so this slide sort of shows both the indication as well as the age ranges for which there is FDA approval. And then on the right, showing the sort of the normal dose ranges. Again, sort of in the general pediatrician's office, as well as, child psychiatrist's office, many patients present having been prescribed one or multiple of these medications. And so in general, the treatment guidelines would be that there's very rarely, if any, indication for multiple atypical antipsychotics. And then again, thinking about the dose range, is a patient that you're seeing at the high end or the low end, and is there room to decrease medications, especially in the context of many of the side effects that we know that these agents have. Next slide, please. So now thinking about the side effects, in the absence of going through the specific medications, the sort of the large categories that we really worry about are metabolic changes, so weight gain, and in particular metabolic syndrome associated with many of the atypical antipsychotics. And so lipid and cholesterol and metabolic labs and routine monitoring are incredibly important. A second subset of symptoms that are quite common in the context of the atypical antipsychotics are the extrapyramidal symptoms. And those can be sort of short-term, which can involve tics or things like akathisia, which is a sort of a peripheral restlessness that many patients, in particular young men, experience, but also long-term symptoms that really sort of indicate, like tardive dyskinesia, that really are sort of largely irreversible consequences of the dopaminergic effect of many of these medications. What I will say is then there's often a question about prolactin levels in the context of antipsychotic medications. In general, we don't recommend monitoring in the absence of symptoms, and that's both in the child psychiatry as well as in the pediatrician's office. If symptoms do present, then certainly looking at prolactin levels is warranted. Next slide, please.
The next couple of slides, we'll just kind of go through in short that delirium can happen in the context of physical illness and metabolic disturbances and fever and sepsis, and that people can have really profound, for example, visual hallucinations. And so if you've had a child, especially in the hospital where you're more likely to develop this, the family may have a lot of concern after discharge, and you can provide reassurance that as long as this has resolved, when the cause of the likely delirium is resolved, then this is not necessarily an indication that they're going to go on to develop a psychotic disorder. So we can go through this one and the next one, and there are resources on the ACAP website. Next.
So just to kind of summarize the points that, actually go ahead. I think for the sake of time, we can kind of just go to the cases if that's easiest.
Yeah, so just wrapping up. So this child really, continued to talk about this hallucination, and then the hallucination would evolve. And sometimes she would also hear a single voice of a male that was more congruent with reality and with just kind of putting her down. And this was really thought to be related to her very profound early childhood trauma and not a psychotic condition. Next slide. And for this young man who had the really significant early neglect and abuse and this family history of bipolar disorder, supposedly, this actually took me some time to figure out that he was actually going on to develop what ended up being schizoaffective disorder. There was a cyclical component to his mood and his presentation, and he had psychotic symptoms throughout. And so the I guess clues were, looking at these gross and fine motor delays and also significant speech delays that could not just be attributed to the early neglect, which was kind of a, what I was initially attributing this to. And some other signals were the pretty bizarre nature of the suicide attempt and ongoing psychosis, which he was kind of reluctant to share about for quite some time. And I know we want to have some time for questions.
Wonderful.